Good to see everyone here.
Yeah.
Welcome, Sushil boss. I think Rastogi sir also. Sir, namaskar. Sir, Anurag sir, shall we start?
Yes, it's 11 now, almost 11. Yes, you can, I think.
11. So I welcome to all of you, and today we are having our first online educational activity initiative, which is named as Pain Gurukul by the Indian Society of Pain Clinicians. The motto of this initiative is to bring together all the esteemed pain practitioners who are actually formally trained to educate the specialities of the people who are interested in pain management. So we are doing its first webinar today, and I am excited to welcome our first president, that is Professor V. Rastogi here. He is the founder president of our society, Indian Society of Pain Clinician. Our ex-president, Professor Dr. Anil Agarwal. Our honorary president, Professor Deepak Thapa sir, and our president-elect, Professor V.K. Mohan. I invite all of you to this first webinar, and we will be heading it subsequently. Every week we'll be having a subsequent webinar in the next sessions. Today we have two esteemed speakers to deliver their topic. One is our president-elect, Professor Deepak Thapa, and another one is our associate professor, Dr. Anurag Agarwal. We are sharing our first topic very soon, and before starting this webinar, I'm going to mute all of you, and if you have any doubt or any queries, you can drop that in the chat window, or if you have any queries in between, you can raise your hand. So shall we start now? So I'll be starting with I'm going to mute first. So I'm starting with Professor Deepak Thapa.
Thank you. Am I audible?
So yes, sir, you are audible. I am pinning your video. So
and I am visible also.
Yes, sir.
Okay. Good morning, friends. I am Dr. Deepak Thapa and President of Indian Society of Pain Clinicians and joining to you from Chandigarh for this first online teaching activity program of the society. At this occasion and on behalf of the Indian Society of Pain Clinicians and the team Gurukul, I welcome you all and members and students to the inaugural session of the Gurukul teaching activity of ISPC. As we know, chronic pain has high societal load and is very devastating to the patient and thus must be addressed logically and scientifically. The teachers in this program are members of the ISPC and are well-known faculty in pain management.
Sir, your audio has gone. Thapa, sir.
Sir, now you can say.
Okay.
Yeah. Sir, you are there. You are audible, sir.
Is it recently gone or should I repeat?
So you are audible. Go on, sir.
Okay. The teachers in this program are members of the ISPC and well-known faculty in pain management. They are course directors in their institutions or they are qualified pain physicians who are trained for at least 1 year in the field of pain management. I myself was first PDCC student from Varanasi in 2009. The goals of this Gurukul program, I could foresee, they are to generate awareness of chronic pain amongst aspirants in pain management and necessity of training and qualification in pain management. Number two, to introduce uniformity in pain management practices and techniques. Number three, to impart stepwise and graded knowledge in pain management. And number four, to discuss recent advances in pain management. All students who have joined here, they may mark their presence as Y, and in the chat box they can also write their names and affiliations so that we can keep a record of that. I firmly believe that the team Gurukul will be able to fulfill these goals. Once again, I welcome you all and congratulate the members in ISPC for this effort and wish them all the very best for this event. I especially thank Dr. Anurag Agarwal who took this initiative and discussed with me, and it was very nice decision, and I accepted immediately. And here we are today to start this program. So at the end, I can only wish, please stay safe with COVID. Jai Hind and Jai Bharat. Thank you very much.
Thank you so much, Thapa sir. It was quite elaborative one. And now I will request the Professor Anurag Agarwal sir to kindly have start their topic. Dr. Anurag Agarwal sir.
So there is no audio.
Hello.
Yeah, it is now. It is.
Thank you, Amitesh. And thank you, Thapa sir, for giving a nice introduction to our online activity with the name of ISPC Online Gurukul. The aim of this activity, as you have already elaborated, is to help the budding pain physicians across the country and world, and also the resident anesthesiology who are our fodder for to become a pain physician. So who might be aspiring to become a pain physician. So I am going to share my screen now. Uh, yes. Is it visible?
Yes, sir. It is visible.
So today's presentation is a generalized presentation, just to give all of us a broad spectrum of pain medicine and emerging specialty or super specialty to all of us, especially the resident of anesthesiology and the budding pain physicians. So this is just a customary disclaimer. This is me. I have done PDCC from BHU, and I am working at Ram Manohar Lohia Institute of Medical Sciences, Lucknow. So these are the topics we are going to cover in today's presentation. That is chronic pain, why it is required to be treated separately in spite of having so many specialties. What is the kind of specialty it is, and what are the treatment and few case histories. So first of all, for our residents, especially, they must understand that why we need to discuss pain medicine, because this is a primary specialty which deals with the chronic pain and spine condition. This specialty is dedicated for the treatment of this thing. This is not about the acute or perioperative pain management. This line is important for the resident anesthesiology and the budding pain physicians. Why? Why? Because perioperative pain management is the integral part of perioperative care, which is already been done with our mother parent branch, that is anesthesiology. So we can help them there, our colleagues, but pain medicine per se deals with the chronic pain and spine management. So, as I said, why it is important to treat chronic pain? Because it has got a very high prevalence. In India, unfortunately, not many studies are available, but a recent study published that told us that there is a 13% point prevalence of chronic pain and spine condition in our India, which is a huge population, and you can see, think that 13% out of 130 billion people in the country, it is a huge proportion of the population which is suffering. And out of these 13%, 63% patients are suffering from chronic severe pain, which are not merely manageable by usually specialties. So we need a primary specialty which focuses on the chronic pain and spine management. That's why this pain medicine has been evolved. So it's a costly problem also, as you understand. When such a huge population is suffering from the chronic pain, it has to be costly. So more than 32% Indians suffering from chronic pain have lost their work hours. That becomes a huge implication for the total GDP growth of any country, including India. So that costs billions of rupees per annum. And many of them, unfortunately, have to change forcibly their profession. They cannot work like before, when they were not having the chronic pain. So what are the common conditions which lands the patient into a chronic pain condition? One, and first and foremost, is lower back pain. One of the most severe and second most common cause of worldwide doctor's visit by any patient or person. Second is osteoarthritis, headaches, migraine, fibromyalgia, cancer pain, neuralgias, and so many different kinds. But lower back pain and osteoarthritis and headaches, like including the cervicogenic headaches, they top the list. So it's as a medical specialty. Let's talk about it. So this is ISPC largely believes, as also the word also, that it is an emerging super specialty of anesthesiology, and this is the primary specialty for wholesome and holistic care of chronic pain and spine patients. The niche of pain medicine is our ability to perform minimally invasive pain and spine interventions. This is the term given by both the bodies, Indian Society for Study of Pain as well as Indian Society of Pain Clinicians. So why anesthesiologists are the leaders worldwide in pain? Let's have a word about it. It is a contentious topic, but I have particularly chosen this to deal with it because anesthesiologist is the only branch where they have been trained to deal and play near the nerves as well as in the spine by the minimally invasive and percutaneous methods. You start with the spinal or subarachnoid anesthesia, epidural anesthesia, caudal anesthesia. You talk about the brachial plexus and multiple nerve plexus. And more than that, you can see the four gentlemen in this slide. First two are considered to be the fathers of pain medicine and fathers of interventional pain medicine. First is Dr. Professor J. Bonica, who actually first time after the Second World War thought that there has to be someone, specific doctor who focuses on the treatment of chronic pain patients per se. Then came the Dr. Prithviraj, who made a history by introducing so much of many of interventions, minimally invasive and percutaneous way to treat different chronic pain conditions. And then comes our own beloved living legend of pain medicine, Professor Virendra Rastogi, who has been the founder of Indian Society for Study of Pain, as well as Indian Society of Pain Clinicians in our country, and who also incidentally conceptualized for the first time that there is a need of structured formal training in pain medicine, and started first PDCC anywhere in the country as a 1 year full-time in-house course at BHU Varanasi. Then comes Dr. Professor Anil Agarwal Sahab, who is also a very dear friend of Dr. Professor Virendra Rastogi sir, and he also immediately started that PDCC pain medicine at SGPGI Lucknow, which he has progressed now to a 2-year course, in-house course in pain medicine, perhaps first in the country, also in the world, in SGPGI with the name of PDAF. But these are not only the few people. You see this use list, and I unfortunately have forced to leave many out of this list because of the lack of space. They all are pioneers as well as the leaders in their different senses. Like you see Dr. Dureja, Dr. Ghedu, Dr. Das, Dr. Sushma Bhatnagar, Dr. Muralidhar Joshi, Dr. Neeraj, Dr. Navneen, Dr. Madhuri Lokapur, Dr. Kailash Kothari, Dr. Pankaj Surange, Professor V.K. Mohan from AIMS. He started first fellowship at All India Institute of Medical Sciences, who everybody knows is a word, one of the most prestigious medical institute. Dr. Sarita Singh, Dr. Ajit Kumar, he worth a mention here because he is the one who has broken the ceiling by starting the first 3 years in-house DM pain medicine course at AIMS Rishikesh. And then comes Dr. Ashok Kumar. He is the first guy who also has done PDCC and started a separate independent department of pain medicine at KIMS Bangalore. But there are lot many more, and all of them are anesthesiologists. So we get a natural claim over the pain medicine as our super specialty. So one question many times is difficult to answer, that is being the anesthesiologist adequate qualification to become a pain physician? By being a virtue of anesthesiologist, you become a pain physician? So my answer is absolutely no. To be a qualified and competent pain physician, you need to learn musculoskeletal, neurological, and neurosurgical examination, orthopedic examination, as well as management, basic radiology, to read your X-rays, MRI, and CT scan. Take my word, you cannot treat a patient with your interventions unless you have the ability to read your X-rays, MRIs, and CT scan before going for an intervention. Basic and fluoroscopic anatomy, which we all learned in the first year of our MBBS curriculum, is again come back in a big way when you start doing the MIPCs, that is minimally invasive pain and spine intervention. Then you need to have a thorough knowledge of working of C-arm fluoroscope and ultrasound machine if you are using that to do your intervention successfully. It is not about pain medicine is not about poking needles here and there. It is about the taking the ownership of wholesome patient and providing complete care. You cannot go behind any curtain if something goes wrong or if something doesn't help. You have to again come back, tackle the problem, uh, assure your patient, and do whatever is required. So this is some question when 2 days back we introduced our online activity to our Facebook. So one of my foreign friend, he asked me on Facebook that this is some peculiar problem he's facing from his peers. So as it is a budding specialty, so there will be doubts, there will be questions. Then there is a question that what do you know about the pathophysiology of pain? You are just good with the minimally invasive pain and spine intervention. So the answer, in my opinion, is the niche. We can take a cue from our fellow branches like the cardiology, gastroenterology. The niche of whole cardiology is ability to perform percutaneous cardiac intervention. So the niche of pain medicine is ability to perform minimally invasive pain and spine intervention. The rest all medications are same, used even by a graduate doctor. So we do use all the available modalities, including the medicines, but niche is our ability to do the percutaneous spine interventions and pain intervention. So as we want to become a pain physician, we know our weaknesses as well as our strengths, and we are working for both. And that is the reason ISPC firmly believes and advocates that everybody must go for a formal training in pain medicine. For resident anesthesiology, a word about that how do you get the taste of pain medicine, because what we have seen in many years, including with us, that during the entire period of 3 years or 2 years during our MD anesthesiology, we almost got never we almost never got a exposure to the pain medicine. After coming to the practice or in our jobs, 4 or 5 years, slowly, gradually, we came to know about the pain medicine. And by that time, for many people, it becomes too late. So for MD anesthesiology residents right now, MCI mandates a pain clinic and pain medicine services for MD anesthesia curriculum. And most medical colleges, fortunately, now having pain medicine services. And as you all know, we all know that our head of the departments or the director of the departments, they all are usually very considerate for the welfare of their residents. So, dear residents, you must request your HODs for at least 2 to 3 months of posting in the pain medicine OPD and services. And then you check, then you decide whether it is a cup of your cup of tea or not, because it is not mandatory that all anesthesia residents should come into the pain. They are required in the mainstream anesthesia services. They are required in the critical care. So check it before when the time is there. How to go into pain medicine? Once you have decided that yes, this is the stream of anesthesia where I want to go, you must receive at least 1 year or preferably more of formal training in a pain medicine after a post graduation. So you should be ready. You should not think that MD anesthesia is the pinnacle of our education. No, if you want to go ahead, you need to learn more and spend more time. There are formal courses, institution of eminence like AIMS, SGPGI, BHU, KGMU, DY Patil Mumbai, and many others are available now, fortunately. Many options. There are this slide just to give you some glimpse of the idea of the formal courses which are being run in country. That is DM Pain Medicine, 3 years at AIMS Rishikesh, PDF, as I told you earlier, at SGPGI Lucknow for 2 years, PDCC at BHU, KGMU, AIMS Fellowship at AIMS Delhi, PDF at Heritage Institute, and so many other MUHS approved fellowship in multiple places in Maharashtra. And very recently, it is a good news to be broken here that FNB pain medicine, that is super specialty fellowship of NBE, National Diplomat Board, is being launched and notified by the NBE this year. And this year, we hope that there will be quite a few centers who will start FNB. So what does a pain physician do? They take, as I told earlier, they take the total care of patients of chronic persistent pain due to any pathology, especially of spine. And treatment options are, this is a whole spectrum, as I told you: pharmacological method, MIPSIs, neuromodulation, neurostimulation, and also includes many non-pharmacological therapy if you are interested in that, or you take the help for that. So what are MIPSI? So again, this is a contentious issue, but it is important to deal here with. MIPSIs are certainly not blocks or injections. As by definition, as we all anesthesiologists know, that blocks are there to abolish the sensory motor sensations or to give a defined area of anesthesia for a certain duration. That definition goes well with the block, but with the MIPSI, we intend to provide prolonged pain relief, perhaps a permanent one. That is the treatment of the cause, and without any sensory motor deficit. So they are not block, they are not injection, they are interventions, pain intervention. So pain medicine, you can take a analogy with the interventional cardiology or gastroenterology, where they intend to do the endoscopy or percutaneous cardiac interventions with the aim of treating the condition once and for all. So they are minimally invasive interventions or procedures to diagnose and treat the pain generator, usually done under with image, some kind of image guidance. That is a must nowadays, either with the CM fluoroscopy or ultrasound guided, or few people also do it under CT guided few interventions. So the aim is to deliver medicines or radio frequency at the precise point of pathology. So benefits of MIPSI are, they are almost painless, they are daycare procedure usually, they are cost effective, they obviate the need of big conventional surgeries and associated complications. They usually done under local anesthesia, so avoid the general anesthesia and the associated complication and cost and their side effects. So you cannot do a MIPSI just roaming here and there. You need to have a dedicated space. Like in this picture, this is our pain medicine OT. Thanks to our director, thanks to our HOD sir, Professor Deepak Malviya. You can see here, there is an endoscopy tower here. You can see this is endoscopy tower. This is CM fluoroscope. There is a radiolucent table. There is anesthesia workstation. And most importantly, your team. My colleague, Dr. Shivani Rastogi ma'am, my pain sister, and my CM guy. You cannot go alone in this journey of pain medicine. You need to have a team, you need to have a space, you need to have the good quality equipment. So lot of sermon, enough of sermon, I think. So now we will go about few interventions just to give the idea of the spectrum which we do in the pain medicine. So there are few snippets of the some MIPSIs for the chronic low back pain, which is, I have already told you, second most common cause of doctor's visit worldwide. Point prevalence of low back pain is 50%. More than, unfortunately, Indian data is not available. More than 8 million Americans are permanently disabled by the low back pain. So it is a huge problem in our country also. So this is one photo of transfemoral neuroplasty. This is a primary treatment for the radicular pain, which is not responding to 4 to 6 months, 6 weeks of conservative care. Very good results, very easy intervention, and dramatic results in most of the patients. So then you see that there is the low back pain or neck pain, especially in the senior citizen category. Facet syndrome is the most common cause of low back pain, which is not going down the leg. That means there is no radiculopathy, and the only worldwide proven with the very good efficacy treatment is radio frequency ablation. Again, percutaneous treatment, minimally invasive, daycare procedure. You do it, you send the patient, and they remain happy, and wonderful results. Then comes the sacroiliac joint pain, which is the cause and unfortunately not duly diagnosed cause of low back pain, especially in the pregnant population as well as otherwise also. Up to 30% of cases of low back pain can be because of the sacroiliac joint pathologies, and it is unfortunately a missed diagnosis. So, normal diagnostic or therapeutic MIPSI with the installation of joint with steroid, little amount of steroid, or if the pain comes back, then the radio frequency treatment of sacroiliac joint provides long-term and wonderful results. Otherwise, there is almost no treatment if the patient is not responding to the conservative treatment. Cancer pain management, very important part of pain medicine, especially for the philanthropic and holistic purposes. It gives you a lot of satisfaction in your heart. It gets you a lot of blessings from the suffering patient who gets relieved with the cancer pain if you manage their pain, because they are afraid of pain rather than dying one day, which they already know, unfortunately. So celiac, there are multiple interventions. We start with the WHO ladder of pain medicine, pain management for cancer pain patient, and then there comes a role of MIPSIs like celiac rhizolysis, like superior hypogastric rhizolysis, for different places of pain due to cancer. We do the cementoplasty for vertebral metastasis. We do sacroplasty. So there are so many indications for our MIPSIs, and they have got a wonderful role. So let's discuss some interesting cases for again to keep you awake and interested. So this is first case. She was a around 50-year-old female with the severe current-like pain in the right side of face for many years, and the pain started after the dental extraction. And pain was being precipitated by speaking, chewing, swallowing, and even by spontaneously. No other complaint. Examination was within normal limit. No sensory motor deficit anywhere in the face. No tenderness. The topographic area of pain was V1 and V2 division of trigeminal nerve. So we made a diagnosis of trigeminal neuralgia. MRI brain was a normal study. She had already taken the carbamazepine, baclofen, gabapentin, but not with much relief, unfortunately. So we planned a balloon compression of gastrin ganglia. So this is just a photo of that patient. You can see a 14 gauge cannula going into the patient's face through the foramen ovale into the Meckel's cave, where the gastrin ganglion is situated. So here you can see this cannula this is the cannula, and this is going into the foramen ovale. This is the perfect gun barrel view, and this is the submental view. So as I told you earlier, you need to have some kind of image guidance to do most of the interventions which we do. Like here we have used the Siam fluoroscope. So this is the submental view. So this is like andhe ki lakdi, or without this we cannot go ahead. Then you see that this is another picture of same patient. You can see that cannula has reached to the Meckel's cave and this guide wire has gone in. And then you see this is a Fogarty balloon which has taken a ideal shape of a pear to compress the gastrin ganglion. This is immediately after the procedure, and here you can see that patient was done with little bit of sedation, not in general anesthesia. So result was wonderful, complete pain relief. Mild hyposthesia was there, which is the acceptable side effect of all the interventions, including surgery in the trigeminal neuralgia cases, intact corneal reflex, and the best thing, freedom from the long-term medications and their side effects. Another case, he was a quite young chap. Actually, he's a medical postgraduate, and he was having low back pain with the severe radicular pain in the late for 8 months. All conservative care he could seek, he had already seeked, and unfortunately didn't work. There was associated tingling, burning sensation, which was aggravating with practically every activity: walking, sitting, cough. Even he was having pain in lying down also. The SLR was 20 degree on the left side, no motor weakness, no bladder bobble. And here you can see that there was L45 paracentral disc bulge, which was compressing his exiting and traversing route both and giving him severe radicular pain. So we initially did a neuroplasty, but unfortunately, after the immediate pain relief, pain came back after 1 week. So we decided to go for the definitive treatment, that is percutaneous spine endoscopy. A word about percutaneous spine endoscopy. That is the latest kid on the block of our pain physicians, minimally invasive pain interventions. And this is the definitive treatment for the spine-related pathology in many cases, and it also saves them from the big conventional surgeries and their side effects. So we did it, and you can see under local anesthesia, all kind of disc pathologies and otherwise pathologies of spine can be dealt with in really minimally invasive and percutaneous method. You can see the patient awake during the endoscopy, daycare, and patient can be sent. He didn't want to stay for even for a one night because he was relieved immediately, and he went back and came back again to show us his results. So you can see that what can be done with the endoscopy. Here you can see this is not the picture of same patient. This another patient. There is a 360-degree compression mainly because of the disc coming out, central bulge, and this is the post-operative picture. Here you cannot see even the thecal sac. Here you can see that thecal sac is well sufficiently decompressed and patient was relieved. Here also you can see that this in the sagittal picture is coming out, and here it has gone. So all these things. This is third case. This is 87-year-old gentleman, trivial fall in the bathroom, severe back pain, unable to sit, walk, no bladder bowel involvement, failed 3-week conservative care with absolute bed rest, bisphosphonates, brace, and didn't work. We examined, we investigated and found the osteoporotic vertebral compression fracture of L2 vertebra, and with a cleft which was not being healed. And we can check it. We did check it on the STIR MRI images. That's why I told you that it is very important to read your MRI by yourself. You need to know what is T1, what is T2, what is STIR, what is fat suppressed, and all kind of basic radiology of the area you are interested to treat with. So we did a percutaneous kyphoplasty, again a minimally invasive, wonderful intervention. We go through the pedicle into the vertebra, inflate it with the balloon and filled it with the bone cement and came back. Immediately for vertebral compression fractures, immediate relief is 60 to 90%. Daycare procedure, amazing procedure for the vertebral compression fracture due to osteoporosis, due to metastasis, or due to hemangioma. So this is immediate post kyphoplasty picture. Babaji was happy. He was walking without, and it is such a blessing to see this kind of patients. So this is the last case. I know I have taken quite a time. He was 45 years old male, banker by profession. He had a history of brachial plexus injury 3 years back. He was operated twice for his injury at C7D1 level. I don't know why. Don't ask me the indication. I didn't operate him. I don't know who operated him, but he was operated. So he landed with the complaints of right upper limb pain, edema, severe tingling, burning sensation, and severe allodynia. Pain was continuous and all that. And on treatment history, he was on multiple analgesic, opioid, neuropathic drugs, NSAIDs, Lyrica, amitriptyline, you name the drug and he was having. And also in between, he was taking IV-14 phenargan on the SOS basis. So we initially did the straight ganglion radio frequency, in which it provided him around 4 months of good relief. But then pain gradually came back. We made a diagnosis of CRPS1 due to failed neck surgery syndrome. And then after the straight ganglion worked for a short while, we offered him a spinal cord stimulator trial. Which is the last treatment for this. And there are few pictures. They have spinal cord lead electrode, 8 electrode lead was placed and stimulated the dorsal columns at C34 level. It was quite hard to go because of the post-operative adhesions and post-operative frozening of the tissues. So we did it percutaneously under local anesthesia. On trial, his pain came down to 2 or 3 out of 10, which was earlier 9 to 10 before our intervention. And there was marked diminution of allodynia also. So after the successful trial, we decided with a team that a permanent spinal cord stimulator with pedal electrode should be done neurosurgically. So we referred the patient to our neurosurgeon friend. He did it open laminectomy and put the electrodes there. So it's a teamwork. So now this patient has been around 5 years now. He's pain-free with increased range of motion of medicines and remarkably decreased paresthesia. He is functionally restored and returned to his work with remarkably improved quality. So all these cases were meant to show you, especially the residents of anesthesiology who are aspiring to come into pain medicine, to show you the spectrum of pain medicine, what a pain physician actually does in his day-to-day life, and what kind of pathologies he treats by his experience and knowledge. So these are the benefits of spinal cord stimulation: safe, testable, non-destructive. And so the take-home message for all my friends and listeners today is pain medicine is an exciting and promising career options for all anesthesiology residents. And I would suggest ISPC firmly believes and suggests and advocates that always go for a formal education. And India is the leader in the education of pain medicine because of the pioneers, many of whom which are present in this seminar to bless us. We have got multiple centers across the India which are imparting quality education, and so come and join. So thank you very much for your kind and patient hearing. Uh, I am happy to take any question if there are any. So Dr. Amish Pathak, off to you.
Thank you, sir. Thank you. It was a very elaborative discussion what you had done in half an hour. Thank you so much. From transforaminal to endoscopic discectomy to intrathecal pumps, spinal cord stimulator, everything you have covered. Thank you so much, sir, for your elaborative discussion. And I'm very sure that many of the new doctors or the new aspirants who are looking forward to join the pain medicine, they must have been got an idea what a pain physician does actually and what a formal training is, because Anurag sir is a formally trained, established, a very known figure in the pain fraternity. So I can see in the chat box many of the people, they want your WhatsApp number, sir, so that they can connect to you. So
I'm not available on WhatsApp, unfortunately. So please mail me or on Facebook.
definitely. So you can mail Anurag sir. Anurag, we will provide you Anurag sir's number. And we are, I have unmuted Dr. Anurag and Professor Thapa. So if you have any queries or any questions you have, you can drop in the chat window, and we can have you one with Dr. Anurag and Dr. Thapa. And meanwhile, we are fortunate enough that Professor V. Rastogi, one of the founder of our pain medicine in India, is with us. And I would like Rastogi sir to have a word. So I'm unmuting Rastogi sir. Sir.
Amidesh, I have a question with Dr. Anurag.
Okay.
In this COVID times, how can the pain practice vary? This must also
May I
due
know?
to the COVID output, COVID breaks, how pain practice should vary.
Sir, it's a very good and pertinent question for all of us and all of the world actually,
Yeah.
because of this pandemic. So there are no clear-cut guidelines. IASP, International Association for the Study of Pain, as well as ISSP have issued some guidelines. But I will tell you my personal experience, what we are doing. So what we are doing, we are taking care of our semi-emergency kind of patients, like the patient who are suffering from cancer pain right now, or with the acute or subacute radiculopathy to do some interventions. Largely, we are providing telemedicine consultancy for our OPD patients and calling them only for the interventions if they require it on the urgent basis, like the cancer pain management or acute
So
radiculopathy.
telemedicine is one option, very good.
Yes, sir. And for interventions, we are asking them and screening them for the COVID before we uh, take them for the intervention. And we are considering every patient to be a COVID positive. So we are taking full care for them as well as for us and our staff while doing the interventions.
What are the use? What are the step for steroids? Using of steroids which are immunosuppressive in patient with chronic pain, because COVID patients they need strong immunity. Can we use steroids?
Sir,
Or is there any alternative of steroids?
Yes, sir. Sir, actually, steroids certainly do suppress the immunity. But fortunately, in pain medicine, we try to use minimum doses of steroid, and that too we try to avoid. Like if the cancer pain management, there is almost no role of steroid. Whatever intervention we do, we use neurolytics or we use the radiofrequency. Same way for the non-cancer patient, like the spine pain, we use steroid. We usually use radiofrequency for the facet radio frequency or the other way around, and there we can also avoid the steroid, especially the long acting steroids. Even if you need to use steroid after the radio frequency to prevent the post operative neuritis, I prefer to use the non particulate short acting steroids like the dexamethasone, that too in a very small doses.
So you want to say that role of radiofrequency and cryoanaesthesia is more emphasized.
Yes,
They
yes,
should be more.
yes.
Thank you very much.
Thank you, sir. I just want to make everyone know that today total participants were around 68, and that too we started in a very short notice. Okay. It was marketed just 2 days back, so I hope that this was a good number. And with this, if we don't have any query, so can we stop the session, sir?
Dr. Mitesh,
Actually,
there are questions in the chat.
Okay.
Please check.
I think they may not be able to ask. Some people are not friendly with the Zoom. They can send chat messages.
Oh yes, there are chat on the chat.
Hey, I have a question.
You, Sushil Gaswal, sir.
Sir, I have a question.
Yes,
Anurag, sir.
yes.
Yes.
Sir, when the brachial plexus injury patient, after doing spinal cord stimulation, why have you sent the patient to neurosurgeon?
Yes, that is a good question. Actually, I answered that. We did the trial and we used the like thread type electrodes. And because that patient has already underwent two surgeries, so the tissues were very hard, and we had a lot of difficulty to enter the epidural space to place our leads. So we thought that there are high chances, because neck is a very mobile area. There are high chances if we leave it there. Though the trial was successful, but we found it pertinent to have the pedal electrode placed. So we sent the patient back to the neurosurgeon to do the laminectomy and put the pedal electrode in the best interest of the patient.
Okay, sir. Thank you.
Okay, regarding the COVID thing, Dr. Avnish is with us. I guess he had been working in the COVID ward. So can we have Dr. Avnish to make a point? Avnish, can you hear?
Doc, uh,
Dr. Avnish?
Dr. Mitesh,
Yes, sir.
I would like to say a word
Yes, sir.
about the future activity of. Dear friends, this ISPC online activity is likely to be continued in the future also, and we will try to encompass the topics which are slightly advanced in the pain medicine curriculum for the benefit of our residents who are pursuing, and for the larger pain physicians. So you all are welcome, and we will publicize the meeting well before, so that you come to know.
So
Dr. Mitesh,
our
more questions
next session will be.
in the on the radio frequency of different kind of radio frequencies. And Dr. Mitesh,
Yes, sir.
few more questions perhaps. You check the chat.
I was. So there's no
Okay, okay,
questions per se.
okay, okay,
There are thank you messages, and you had a
okay,
great talk. That messages are there.
okay, okay. Hey, Dr. Abdul
As you have
Rahman
been said,
Khawaji. Dr. Abdul Rahman has asked, okay. Sir, you have this. Congratulations that you have done your fellowship in Canada. Uh, for hands-on experience, hands-on would be difficult until unless you join a formal fellowship in India, full-time fellowship. So there are few options for the foreign national. I believe that you are situated somewhere outside. I think that there are few opportunities like the DY Patil in Mumbai under with Dr. Siddharth, he perhaps is here, or Dr. Gehedu Saab. they are offering it for the foreign national also. So there you can try, and there you may get the admission. And
So there is one question from Dr. Divanshu Lal, that has any institute applied for the FNB pain medicine?
uh, Dr. Dipanshu, FNB medicine has just been notified, and because of Corona, unfortunately, no institute has yet a, been able to pull it through. So we hope that the coming August session should be open for the students, and then you will get the information which institute is providing the FNB.
Another question from Dr. Hasim, and he asked, what are the good centers to pursue the formal pain management fellowship?
I have given you a list. You might have missed the list. I will again share. There are many more. I have included just a few. And on our Facebook wall of the ISPC, you can find the exhaustive list of uh, centers which are providing pain medicine education. So I am again sharing my screen to show you this thing.
So as
So,
Dr.
dear friends, we have a website ispc.in in which various pain management courses have been listed. Also.
Yes, yes.
Kindly visit ispc.in.
Yeah.
Thank you.
So you will get the exhaustive list of courses available in India.
Definitely. So as Dr. Siddharth Verma has already mentioned in the chat window, that there is no inspection has happened till now, and Siddharth has he might be applying for the FNB course, and he is expecting the first seat in the January 2021. So definitely by 2021 we are going to have an FNB course in pain medicine.
No, course is
And
already there. We will have the first batch.
we will have the first batch, correct?
I think.
So another question is, can you put some light on the DM pain at AIMS Rishikesh?
What is there to be put in light? This is there. The second batch has been, first batch is already studying. Second batch has been, I think, entrance exam is about to happen. And this time they have got regular seat as well as private sponsored seat also. So if anybody interested, visit their website and you will find all the information. Yes, that is the first and formal first course in the country, as well as perhaps most likely in the world, which has got the 3 years duration. So you are expected to become the completely proficient as any other super specialty branch in pain medicine after doing the DM pain medicine.
I hope everyone clear with the queries. Any new query you have? GM pain medicine. Any
So
more queries? Anyone? You can drop in at the chat window. We're there for 10 more minutes. So every weekly, we are going to have one interactive session of the Pain Gurukul, the initiative which has been started to train the people who are interested in pain medicine by the formally trained people. So next week, we are having a session on radio frequency versus the cool radio frequency thermocoagulation. So there is one query. Along with anesthesiologists, which other branches can pursue pain medicine? Dr. Anwar?
uh, there are many people actually. There are many people from other branches. They are pursuing pain medicine by their uh, mm, uh, interest. Uh, so this is a time of merging. But most of the courses which I have mentioned in our list, they allow DMO, MD, or DNB anesthesiology as the eligibility for these courses.
Okay. shall we continue with the session? Some
Yes.
more queries do you have, everyone?
I think it's all. So please give a thanks note.
Thank you so much,
Akas-
everyone. It was a good session. And thank you so much, Professor Deepak Thapa and Dr. Anurag Agarwal, for an elaborative discussion of the Pain Gurukul, online Pain Gurukul. We will meet soon next week, the coming Sunday, I guess. So we will publicize this more regularly this time, so that the attendance will be much more than the. But we are happy with the participants today. We got around 70 people, and that was a good initiative. Thank you so much, everyone. Thank you so much, Anwar sir.
Thank you very much.
Papa sir.
Thank you very much. Thank you to all.
Thank
This is
you.
a very nice
Keep safe.
presentation, and
Everybody, take care of yourself as well as your patients.
yeah,
Thank you. See you soon.
stay safe. Stay.
Thank you, sir.
Namaskar.
Thank you.